everyone present here in our MRCP PACES webinar, where we have Dr. Asif Iqbal sir. He is a founder of Farz Academy. He look after all the Farz Academy courses. Then we have Dr. Tanmoy Banerjee sir. He is a director of PACES course. And then we have Nandini ma'am, Dr. Nandani Biswas. She is our faculty in MRCP PACES. And also we have Dr. Varun Pushkarna sir. He is our faculty in MRCP PACES courses. So, Dr. Asif, sir, I would like to invite you to share something about Farz Academy and about PACES, please.
Yeah, hi. Hello, I'm Dr.
Hello.
Asif Iqbal. I'm the senior consultant in Respiratory Critical Care Apollo Multispeciality Hospital, Kolkata. So, we have started this journey of MRCP in Farz Academy since 2019, and now it's a well established course. We are servicing 122 country, and we have a per year we are serving uh, more than 1,000 students in MRCP Part 1, Part 2 and Spaces. And we have started our physical PACES course from last year, 2025 February. And it is a very well successful, well structured courses. And also we have started the online and the offline both in PACES, because if you see that the MRCP course, the MRCP part 1 is bit easier, but part 2 and the PACES both are very tough. In the PACES, I will not talk about it is a very tough, but it needs skill and time management, where our faculty is all are very expert, and uh, they are very well uh, credential. They have a very good credential. They are well established, and few them are also have a real examiner experience. So uh, they do they help for this course is well structured, and we try to do our mock test as similar as the real exam. So there are a lot of review from the past candidate that they said that this course helped them to habituate in the real exam. So I will not take much time. Dr. Tanmoy Banerjee is a course director of MRCP PACES of Farz Academy, has already joined, and Sir will tell you about the insight of the course, and then we have a eminent faculty. They also give you the idea and the tips and tricks for successful getting a success in the MRCP PACES exam. We have the real course in the February 13, 14, and 15 in Kolkata. Usually, we keep more than 100 different actual cases which come in the in the exam. The similar, I will not say the same case, but it is a pretty similar, same case but not same patient. So pretty similar cases, and we try to do our mock test as similar as real PACES exam. So student, if you have any doubt, we will do question answer session at the end of the lecture. So beware with us, and you clear your doubt queries from the expert. Thank you.
So, Dr. Nandini ma'am is our MRCP PACES faculty. She is a senior consultant and pulmonologist. Dr. Nandini ma'am,
Thank you. Thanks for inviting me today. I'm Dr. Nandini Biswas, a consultant pulmonologist. I thought I'll start with communication, and also because I've already shared my slides. So I we should start. Let's get going. And before we actually come to the clinical content of the online course, communication, consultation, professionalism is something that's very important and needs to be discussed. It's a subject which is not taught very much in our day-to-day practice. It's not taught in our country formally either, but it's actually very, very important that you establish yourself as a confident professional, that you establish a good physical and eye contact, that you induce some sort of confidence amongst your patients and your relatives before you actually kickstart, whether it's your clinical consultation, whether it's breaking bad news, whether it's information giving, or you're trying to receive an information. So that's why I've labeled the slide communication, consultation, and professionalism, because at the end of the day, professionalism, empathy, these are all very important. Knowledge is very important. You should know what you're doing, what you're trying to understand, what your specialty is, what your subject is. Medical knowledge is very important, but delivering it with empathy, applying it professionally is very, very important. And when you take MRCP exams, that is what you're marked upon. The first impression, the way you enter the room, the way you sit down, the way you what your body language is, how much eye contact you make, the clarity with which you introduce yourself, the clarity with which you talk to the patient or to the patient's relatives, that is very, very important. And when you take an exam, the first impression does matter, because if the first impression or the impression as you enter the room, as you start your consultation or you start your communication, if that is started on a wrong footing, then the whole thing might just go the wrong way, even though you know your subject and you know what to do or what to tell. So communication station, so this is what I was trying to say. Lots of us in our Indian subcontinent or in the Asian setting, we somehow have a different perception, isn't it? So the doctor is dwells at one level, the patient or the patient relatives dwell at another level, and English is not our language. Eye contact, are talking confidently while looking at the patient or the patient relatives is not encouraged. We somehow say something, we mumble something, and we carry on our work. So it's not part of training. It's there are unfamiliar social practices, and as I mentioned, a different doctor-patient relationship. But this is not the end of the world. It can be learned. It can be learned while you're taking part in while you're taking your MRCP exams, and once you qualify in your MRCP exams, it can be part of your regular day-to-day practice. So it's very important, and a lot of candidates actually fail in this station. So what is the utility of the station? So gathering history. So there are a few things that we do. We either do a clinical consultation. So we first gather information from the patient or patient relatives. And then once we have a diagnosis in mind after examination and all the tests and everything, we have to provide information. We have to tell the patient or the relatives their diagnosis. And once the diagnosis is given, then you need to tell them what investigations we are going to do. And once the investigations are done, the examination is done, and we need to tell them what the prognosis is, what the condition is, what the treatment is, and what the long term prognosis is. Are they going to get better? Are they going to remain the same? Are they going to get worse? Will they survive long term? Will they not survive? Is this a bad thing? Does it carry a poor prognosis? So various types of information need to be given depending on the clinical situation and the clinical context. So gathering information and delivering some information, which is rather complicated, and it's not something the patients deal with on a regular basis. So that providing some that information in a structured yet simple form in a language the opposite person people can understand, it's very, very important. So being able to gain confidence amongst the patient or the caregiver is very important. If there is something bad news that we need to break, that needs to be done with empathy and sensitively. You can't sit in the chair, say, I'm so and so, I'm very busy today, but this is what's wrong in the patient, and shoot off from the room. You can't do that. If there are conflicts, if there are problems, you need to resolve them. After all, you're the doctor, and everybody looks up to you to solve the issue. Ability then amongst your colleagues, you need to be able to connect with your colleagues, your juniors, your nurses, and everybody in a way that people know that you're in charge, you know what is happening, you know what to do, and you're able to work together as a team. So convey all necessary information in a structured and succinct format to colleagues and to ensure safe and effective continuing care. So preparation, so I'll skip this slide. So before you go for a clinical consultation, or you are about to break bad news, have a mental note in mind what you're going to say, how you're going to say, how you're going to start, and how you will, if I may call it, modify the blow in a way that they're able to understand what's wrong, they know what treatment options are there, and when you say something bad, don't take all the hope away. So, if somebody has got very poor prognosis, somebody is critically ill, you should be able to give them a ray of, while being honest, should be able to give them a ray of hope and say, while we cannot do a lot about this, this is what we are going to do to make things better or make the patient comfortable. So if it's bad news, you should know how to break the bad news. Introduce yourself first and check who the person you're talking to is, not knowing who you're communicating with, who the next of kin is. Is it the patient's wife, patient's husband, patient's a son or daughter, patient's cousin, whoever it is? It's very, very important that you know the person you're talking to. Not knowing exactly who you're talking to, not knowing how much that other person knows. So it's very important that you know how much they know. You'll be surprised that a lot of people actually do understand a bit, at least, about the problem at hand. They might have some knowledge about the clinical condition that you're about to explain. So, first of all, assess who the person is, how they're related to the patient, and how much understanding they have about the problem. So, they may not know anything at all, they may be completely in the dark as to how bad the condition is, or what the condition is, or how sick the patient is. Or surprisingly, they might have an idea because they have looked after the patient for a very long time. Don't rattle off what you know without pausing, without giving chance to the other person to react. So wait for response. Go at their pace. Don't just, it should not be a monologue. When you deliver some news, you should wait to see how they react. They might be silent for a minute, they might be stunned, they might be horrified, or they might be expecting what you had or what you have told them. So wait and assess their response, and then let them talk as well. Sometimes they may not talk, they might go silent for a few seconds, and that is okay. They might just be digesting the information that you have told them. If necessary, be prepared to repeat the whole thing again, because they might say, "Sorry, doctor, I haven't understood really what you have said. Can you please repeat it again?" Or they might say, this is completely unexpected. I did not know that this was how bad the situation is. So be ready to go at their pace. Be ready to explain the whole thing again. And if there's an information that you want to gather, how long they have been, if it's a patient consultation you're doing, if if there's something complicated you need to ask, something sensitive you need to ask, then go at their pace. So you should start by saying at least how long have they been feeling unwell, what their perception of what their problems and symptoms were in the past, and are they aware of what the problem might be now they've come to see you. So always, it should be a dialogue, it should never be a monologue. You wait for the other person's response, wait for the other person to react. Sometimes the whole thing might be just a silent a pause, which or might be met with silence, and that is okay. You can then ask, shall I start again? Do you want me to repeat what I said, or shall I do you want to ask anything? So just wait for the other person to respond. Sometimes the response might be anger, but that is also okay. But just remember that you are talking as a doctor, but they are dealing with a situation that might change their next of kin's life, their own life, forever, for good. And what a doctor says as a part of diagnosis or information is something that can change the opposite person's life forever. So I give them that space, give them that place for some sort of emotional turbulence, if you call it. And when you finish, summarize and check. So you should say, so you should say, so we can say that this is what has happened. This is the test we will do, or this is what the diagnosis is. This is the treatment that we are going to try, and this is what we can expect. So this is the structure you have to follow. Always make a mental note, and the more you do it, the better you will get at it. But very important, empathy and understanding is key. We do not come from a place of arrogance. We come from a place of understanding and empathy. Most of the communication is non-verbal as well. So as you enter the room, your mannerism, your the way you look, your eyes, your body language is very important. So professionally dressing yourself, eye contact, facial expression, gestures, these are very, very, very important. So gender name must get very, very, very important. You should, as I already mentioned, sometimes people have a whole dialogue and they do not know who they have spoken to, and that can be legally and emotionally very wrong. We are supposed to talk to the next of kin or the person caring for the patient. So if you don't know whether the person you're talking to is a doctor, is a daughter or a wife or a niece or a cousin, then you start on the wrong footing. So very important that you get the name right, and you get the patient's name right as well. So and the patient should be addressed to him as her, know it. So very, very important. So know the person you're talking to, know what you would ask, what they would like to be called. Would they be like to call by name? In our country we normally don't do that. Are they, should if it's a wife, then if that person is a wife, then would the way they would like to be addressed, or some sort of way that it looks nice and with filled with empathy. So nothing should be abrupt. The important information you need to give or gather, and what the patient or carer wants. So these are two aspects you deal with. If you are doing a clinical consultation, you should know, you would have an idea what might be wrong with the patient. You're doing a specialty clinic, so you would partly expect, if it's a chamber, it's a clinic, you would partly expect what the condition might be. So you would have an idea of what information to gather, the current history, the current clinical problems, the past history, family history, what their comorbidities are, what medications they are taking, what to expect. So this is a part of clinical consultation. Once that is done, you do the examination, then you tell what your provisional diagnosis could be, what tests they might need, and what you would do after the investigations are done, or what treatment they might expect. If it's breaking bad news, or if it's giving some sort of information or diagnosis, then you should know what the key information that you need to give. So if they have had a stroke, or if they have had a heart attack, or they have got pneumonia, then you need to tell them in layman's term. You cannot tell them, oh, your father has got lobar pneumonia. That doesn't mean a lot. You should tell them that your father or ex person has got infection in your lungs, on your left lung, bottom bit of your left lung. There's a lot of information. This pus collecting, so it's pretty serious. We have to give antibiotics and see how they respond. So it should be in a layman's term that they can understand, while at the same time emphasizing how sick or how serious the diagnosis might be. You need to emphasize the degree of illness, without scaring them so much that the rest of the consultation goes completely blank. Then you need to tell them if it's a consultation, what the treatment might be, or if it's information, giving information or breaking bad news, then tell them what the news is and see what the patient or the carer wants, what the family wants, and what the patient, if it's a patient clinical consultation, what they want. And as I said before, you will be surprised. Sometimes people don't know anything, they don't have any idea about the seriousness of the condition, and sometimes they do have a bit of information as they come and talk to you or see you. Especially in today's day of Google and artificial intelligence, I would suspect that people do have a bit of an idea, may not be entirely the right idea, a bit of idea what to expect or how things, how bad or not so good things can be. So, as I said, again, this is repetition needs to be a dialogue, not a monologue. You're not the person who dwells at a superior level that you can rattle off without waiting for the other person's response and leave. Silence, as I said, is not awkward because sometimes the other person might take a bit of time to respond or to digest the information, and listening, as I said, is as important as talking, if not more. General rules: if there's a conflict resolution or something has gone wrong, the patient has been injured, or you've poked a patient several times, or some harm has come out of doing a procedure, or some drug error has happened, or something has happened, somebody has misbehaved or not behaved appropriately, be ready to apologize. Apologize with all readiness. While we don't need to grovel, but we need to apologize if things have gone wrong. If you start with an apology when appropriate, things cannot go more wrong after that. So, accepting liability, saying sorry, is very important. If you own up to the mistakes that have happened, whether it's done by us, by somebody in our team, or paramedical peoples around patient care, then then you can expect that nothing major might happen. Again, body language, open posture is important. You cannot dominate or hog the limelight. You have to talk at a similar level to the other person sitting in front of you. Switching off phones is very important. Your phone can't go on and on and on as you are trying to say something important or serious. Um, and if it's breaking bad news or it's apologizing for an error that has happened, it's better if you take somebody with you as well. It just helps that bit. No table in between. This is sometimes difficult to achieve, but it is important because the moment there's a table in between, then there's an invisible barrier that comes up between you and the patient or the patient relatives. So try and talk in a room where there's nothing in between, that it's a comfortable professional room and you behave professionally. And you are marked on these things. We all do that. So please bear these in mind. Breaking bad news, again, it's repetition. So preparation, what to say, body language, empathy, confidence. Warning shot, just saying, have a seat. How are you? Do you want a cup of tea? I'm afraid I've got something to tell you that doesn't sound great, or I've got something to tell you which is a bit serious. So just give them a slight warning, and then you start breaking it down and say what the presentation was, what the tested results was, and this is what you have found, and some hope if possible. So say, while there is no definitive treatment, we cannot cure the problem, but we can make his life better, we can reduce the symptoms so that he can live comfortably. So don't take hope away completely, don't shatter them to the point that they can't get up and gather all the pieces. Just modify a bit and give some hope that we'll do all we can to make things bit better or make symptoms less troublesome. uh, so, breaking bad news, again, these points you have to remember: warning the patient relatives that bad news is coming, may lessen the shock. Unfortunately, I have some bad news. So, these are the opening statements that you can use. I'm sorry to tell you. Start of level of comprehension. So, don't use medical jargon, use common terms that we use every day. And first, understand what they know, what they understand already before you start talking, and whether they were expecting something bad or whether completely in the dark. So that is where you start. Use non-technical words, avoid medical jargon, and don't be too blunt. You don't want to be too blunt, you don't want to be too rude, you don't want to be too soft. Just enough that you're a doctor, that you have found, and this is what it is. So, no blame game, nothing. Don't interrupt when they're talking. Don't lose patience and don't definitely be rude. The other person might shout at you, the other person might be rude to you, but just understand and try and put yourself in their shoes. Don't be dismissive even if you think that the idea is completely wrong and you don't agree with their point of view. Try to convince as much as possible that you're on their side and working for the best interest of the patient. So, this last point is very important. They should be seen, they should try and see you as somebody who's trying to make their lives better or their next of kin's life better, not somebody who's trying to blame them or accuse them that they haven't come on time, they have delayed the whole thing, they have done the wrong thing. So that is not what we do. So empathy and body language, as I keep on saying all the time, must not lie. If you don't, if there's certain, sometimes we don't know all the facts, we are not encyclopedias. So if you don't know something, so please tell them that I'm not sure, but I'll find out and I'll get back to you. All factual information must be correct, otherwise it's a clear fail. So if the examiner thinks that you're saying something rubbish or bullshitting, then obviously you do not pass. So be absolutely sure. It's nothing wrong in saying, I'm not 100%, but I'll find out and get back to you. You can say this in an exam setting as well, but do not say things that are not right. You'll clearly fail. That is very important. Important to reassure, but appropriately. Don't say, don't worry, there is a lot to worry about. So you cannot give a cancer diagnosis that's spread everywhere and say, don't worry, things will be okay, because things will not be okay. So say, yes, it does not look good, but we'll see what we can do. We'll try and give as much treatment as possible and make sure that, the symptoms are well controlled. So obviously, don't say, don't worry when the situation doesn't look good. Think about how you would answer when they ask, is she going to be okay or is the other person going to die? Offer support as appropriate and volunteer to find out if you don't know anything straight away. So, when you give a bad news, particularly a life limiting illness diagnosis, tell them, whether they need any social support, whether they need any nursing support, any physiotherapy support, any home help support, any nutritional support. These things are very important because often the relatives of next of kin find it difficult to cope single handedly. So tell them that you will do all you can with whatever treatment options are available, that you will do what you can and that you will try and give symptomatic relief, that if necessary you'll involve other specialties so that the patient is given the best of whatever treatment options are available. And if you don't know anything, please tell them that we'll go and find out and get back to you. So no wrong facts, please. If there's an untoward incident, there's a repetition, emphasize, say sorry, apologize, emphasize that it will be investigated properly. Don't name or shame anybody. We are here to make the system better. It's like airline industry. We're here not to play blame game. We are here to make the whole medical care and experience better. So say that we'll find out what the cause of the mistake was and we'll ensure that the situation is rectified and reassure that this will never happen again. So, but also give them the option that if they want to make an official complaint, that they are free to do so. And if they want to know how to go about complaining officially, please give them the appropriate information. When things are out of control and if you think it's a significant issue, then escalate to the higher authorities as appropriate. Okay, but own up that something has wrong has happened, apologize and say that the investigation will be done properly so that such things never repeated in future. um, so conflict resolution, no threatening attitude, no blaming attitude, you'll never pass MRCP if you do that. Body language should be empathy while try to gain, yes,
हाँ,
try to gain confidence.
एक सेकंड
Sometimes, they just
सुनिए ना,
listen.
वो जो आपको नेम प्लेट दिया है, वो मोटा पेपर में प्रिंट करवा लीजिए.
try and
ठीक है
listen.
छोड़िए रखिए
Sometimes listening will just help. They
हाँ
might have a lot of anger within. Sometimes just saying that out loudly just help and might resolve the whole conflict, and explore the reasons leading to the conflict and offer support as much as possible, and escalate when situation goes out of hand. So conflict resolutions is sometimes something we need to do very often in today's day and age, and it might come as a MRCP scenario as well. So breaking bad news and conflict resolution is very important. Explaining a diagnosis, again, when you have a diagnosis which is rare, which is genetic, ask if there's anybody in the family. Family history is very important. If you don't know anything, if it's a rare diagnosis, tell them this is what the diagnosis is, and as and when you have more information, you will get back to them. um, and obviously, and if you don't know this wholly the whole diagnosis, or tell them that you will find out and you will get back to them. So what I'm trying to say is, if it's a rare diagnosis, tell them this is the diagnosis is, if there's any family history of similar symptoms, and this is how much you know, and as you gather more information, you'll talk to your colleagues and you'll come get back to them. So very important. So that's all. So
thank
actually,
you
if
yes ma'am
even though, yes, so even though it sounds like a lot of slides, it's actually, it just boils down to few things: that you have a confidence, and your posture is one of confidence and empathy, that you introduce yourself, you dwell at a level that is at par with the patient or the patient's relatives. You don't dominate them. You talk to them with direct eye contact, with empathy, at a level, in a language that everybody can understand. You gather history and give information in a language that the other person is able to understand, and no medical jargon, and have empathy, and say sorry when appropriate. I hope this is helpful, and good
yes
luck.
ma'am thank you it's a very informative session we would like to invite Dr. Varun Pushkarna sir now.
Good evening, everyone. Good evening, Dr. Asif. Good evening, Dr. Nandini. A nice class there.
Good
A
evening.
very good, informative lecture there. I was given a title of, high yield approaches for each system while we are doing PACES exam. Now, this is basically, we need to understand that the examiners, they are not testing how much we know. Nothing. They already know that you're well prepared, you've cleared your part one, part two. So they know that you, as far as academics is concerned, you are primed up. They are only testing how safely do you examine, how safe the patient is with you when you are examining the patient, assessing them, how clear is your thought process, are you able to relate the findings to the plethora of diagnoses that are there, are you able to connect the dots, are you able to reach to a definitive and a justifiable conclusion, and how confidently can you communicate all those things. So it is not a trick exam. It basically is a standardized clinical competence test which they assess you on. So don't be fearful. Just do what you normally do. Examine the patients. Examine the patients pretty well. So what is the basic PACES examination philosophy? The golden rule is first you look around. So when I appeared in the exam, I remember there was a patient who was probably a chronic, bronchiectasis patient. And when I went into the room, I saw this patient who was emaciated, thin, trying to breathe out of turn. He had a walking stick by the bedside. He had one leg amputated. There was a nebulizer kept. There was an oxygen mask also, an oxygenator in the room, and a pulse oximeter placed nearby. He had few inhalers kept. So they want you to observe what all is happening around. If you see there is insulin kept by the bedside, you should get a fair amount of idea that the patient you're dealing with is probably diabetic needing an insulin. And then try to think, link the findings that you see. If he's a pink puffer, if he's a blue bloater, if he has ascites, if he has pedal edema, if he has distended jugular veins. And these are little things that you immediately come across when you see the patient, even from a distance. And when you are done with whatever examination you performed, you should present it clearly, concisely, and confidently. And that doesn't happen without practice. So, what you should do is don't rush, don't over examine, develop a scheme of examination, and do not relate the irrelevant facts that you feel that are not important. So, I have just devised this. Many people make their own ones. So you should actually internalize this 5-step framework. This is universal structure for any examiner, any system that you are going to examine. Number one is introduction and consent. Tell them who you are. They don't know. Even if they know, they deserve to know who is going to examine them, who is going to put hands on them. So wash your hands, confirm the name of the patient in polite manner, explain that I'm going to examine you today. And if it is a cardiovascular examination, you might need them to expose their chest. So you need to tell that to them and then ask. For example, if you are going to examine a cardiovascular patient and you are going to check for hepatojugular reflux, always ask the patient if they have any pain in abdomen. If you're going to check for a water hammer pulse, you need to ask them if they're having any pain in the shoulder. You don't want to give them pain while you are so engrossed in looking for a clinical sign. You cannot give them pain. Inspection, the highest yield step. You should always start at the end of the bed. Look for clues, not the beauty. So examples are look for oxygen, look for catheters, mobility aids, scars, deformities, cachexia, facial features in thyroid, Cushing's and acromegaly are very important features. Then perform a focused examination, do whatever is relevant. PACES will always reward you for your precision, not completeness. You should aim like a BrahMos. You should aim for what you want to see. If you have a thought in the mind, if you have a targeted approach, a scheme in mind, you will always do whatever is necessary in the given amount of time, and that only happens with practice. You cannot create something there, it's already there. You just have to follow the same protocol and routine that you are already following. Then targeted special tests. Now this is only done only when indicated. For example, if you think that the patient has a thyroid disease, you would like to check for lid lag. This is a special test you would do only if you are thinking about thyroid disease. So that gives an impression to the examiner that yes, you understand the things, that you know what you are doing, that you want to elicit something which probably another student has missed. So don't do it randomly. Once you're done with complete examination, try to do whatever you think is important and then close it. Close it with thanking the patient. Tell them, okay, thanks. I've completed my examination, and uh, if they are okay now and step back confidently, you don't have to ask any questions to them, because in PACES, it is just about examination. Now, just system-wise, few points. Examiners want in cardiovascular system that you should be able to recognize any murmurs, any valve disease, any clues that are pointing towards heart failure. Always check from hands, go from pulse to blood pressure to the neck. So this is the scheme that I would follow, from hands to elbows to shoulder and neck. So this gets you pulse, BP, JVP in no time. And JVP is the gold mine. And then check for any hepatojugular reflux. Peripheral signs should always be checked before auscultation. People directly go for auscultation. That is wrong. Now, try to tell them in this pattern that I have written here, like this patient has features consistent with. Don't say, I feel. Don't say, I think. Try to put them in perspective that this patient has features consistent with or suggestive of chronic severe mitral regurgitation. Then comes the respiratory system. So when you are asked to go into a respiratory station, you need to identify the pattern. See, there will always be 3, 4 types of patients. One would be COPD, another would be ILD, another would be a chronic effusion. See, you won't have an acute bronchial asthma patient kept in the examination. Obviously, these patients would be there who are chronic patients. So never miss certain features that they would like to see, because routine things everybody will do. Don't miss the tracheal position. Don't miss the chest expansion symmetry. Look at it from the foot end, then examine it with your hands, palpate it. You must be able to demonstrate it in the light of things. Then you have to percuss before you auscultate. That is very important. Don't do it the other way around. And never ever miss quoting that you need to check oxygen saturation in this patient, specifically in cardiovascular and respiratory systems. Never miss. They would ask you, is there anything else that you would want to check? Yes, I want to check for oxygen saturation. Then comes abdominal examination. Now, see, abdominal patient definitely would have certain abdominal signs. So you have to be very, very careful when it comes to palpation and percussion. You have to be calm yourself, and it has to be a systematic palpation, and the patient should not be pushed into distress. You should be able to identify clearly the liver and spleen's location, the size, and if they are palpable. If you feel a mass, just stop and think, is it really there? Is it an organ or just a lipoma? Is there any edge? Or and how is the surface of the mass? And does it move with the respiration? That would give you, even if you quote it wrong, but then you should have this in mind, because you can be wrong, but at least you performed it well and you checked it well. And because these are the questions they're going to ask you in examination. Now, as far as the neurology is concerned, it always scares everyone. It's a reality check. They don't want you to be a neurologist. They just want you to, understand and perform in a proper scheme. So, strategy is to identify if it is an upper motor neuron or lower motor neuron lesion. They'll ask you right away. So, check for the signs. Differentiate between central versus peripheral, like neuropathy, like uh, myopathy. You can actually find out if you have a scheme plan, acute versus chronic. Then comes high yield systems, gait, tone, reflexes, and pattern of the power. This pattern suggests a chronic upper motor neuron lesion, most likely due to this. So we use words like suggests so that they also understand that you are likely to place the findings with respect to the knowledge that you have. So you're not imposing anything, you are not fixed, you are not anchored to a diagnosis. Then comes endocrine. Endocrine, acromegaly, thyroid patient, diabetic patient, who else? Cushing's patients. So these are the patients that you will get in the exam. So look at the hands, look at the face, look at the posture, look at the way they walk, look at the shoe size, look at the ring size, the walking aids present by the bedside, little things. I mean, these are so important. They will take you places, and the examiner will be very happy. So common PACES diagnosis, other ones are rheumatoid arthritis, ankylosing spondylitis, thyroid, and steroid effects. All of these, they will be kept in the exam. So you should have a fair amount of idea. Then there are certain red flags that you should never miss. These are, fail preventers. If you look for cyanosis under the tongue, under the nails, look for clubbing, and then look for severe anemia, signs of heart failure, any any spinal cord compression signs, sepsis clues, and Cushingoid features. If you are missing these, you are going to fail for sure, because these tell that you are, going to. These are the red flags. You should never ever miss them. So there is no perfect formula, but I can suggest you some. You can speak like while presenting. On examination, this patient has key positive findings of one murmur, which is more localized in the aortic area, which is radiating to the both carotids. It increases with Valsalva, it decreases, so on. So I feel these findings are suggestive, or they are in line with aortic stenosis. So this is how you should say these findings are consistent with aortic stenosis or aortic valve disease. Then they'll ask you what kind of aortic valve disease. Then you can say presence of ejection systolic murmur radiating to carotids is most likely due to aortic stenosis. So these are the features. And then you can say that there are no features of aortic regurgitation. He doesn't have a water hammer pulse. He doesn't have a Corrigan sign. So you can always say the negative findings also. They'll be impressed. So be very, very clinical. And then have good confidence. Stand still while speaking. Don't apologize unnecessary. That doesn't show confidence. You are a doctor after all. If unsure, say what you know safely. I, because the examiners might ask, what else, what else, what else. In when I was appearing, there was this patient who had an aortic stenosis murmur and a pulmonary stenosis murmur both, but I could not, place my finger on the pulmonary stenosis murmur sharply. So I said aortic stenosis only, and then the examiner asked, "What else?" So I said, "Yeah." To add to it, I could hear a faint murmur in the pulmonary area, but I'm not sure. So they like that. And the examiner actually said, yeah, there is. He also has a pulmonary stenosis. So that's wonderful if you can identify and present them nicely. Silence is not failure. If you don't understand, don't speak. Confidence is not arrogance. Yeah, overconfidence could be. Examiners, they always reward and save doctors like any patient would. They are not examiners, they are your patients. So in PACES, you don't need to be perfect. You just need to be structured, safe, and clear. If you examine like a consultant, the examiners will definitely treat you like one. And there is no substitute to practice. Practice out loud with timing and with feedback. That is the secret of PACES. So that was my brief talk. Uh,
Well, sir, thank
I
you.
think
As you know, we'll be having our MRCP paces on 13, 14, and 15 Feb. Uh, so we'll be moving with Dr. Tanmay, sir.
Yes, welcome you all. And I think I'd like to thank Dr. Nandani Biswas and Dr. Varun for very nice presentations about communication skill and also clinical station examination. Now I would like to give you a brief idea about the PACES carousels and the PACES exam itself and our course. And then we can take up some questions from the audience if they're ready. So, Sana, if you can just put up my slides. Yes, so as you know that quite a few centers in India and like a lot of centers abroad in UK and all over the world. But in PACES exam, there is a standard format which is followed for the examination and the marking. That is what I'm going to discuss now. So next slide, please. So this is probably something you need to know. Those who you have already known, I would just like to explain to everybody that there are 5 stations. No, the previous slide, please. Yeah. There are 5 stations, and each station is 20 minutes, and there is a 5-minute break between the stations. So station 1, communication skill and respiratory. Then station 2, consultation or BCC. Station 3, cardiovascular neuro, and station 4 is again communication and abdo, and station 5 is BCC again. Now, what is important to understand that this 5 minutes interval before the communication skill station and BCC stations is to be utilized for planning the station. So, at the beginning of the 5 minutes, you will be given the scenario that the communication skill station you have to explain, or the BCC station that you have to take history and do consultation and examination. So you'll be given a brief outline of that at the beginning of this 5 minutes. So you have to utilize this 5 minutes to prepare for the station. So mostly before station 1, station 2, station 4, and station 5, you can see that these are the sort of stations that you have to prepare in these 5 minutes. And before station 3, definitely you will get some rest. Apart from this, there may be rest stations also for 20 minutes if there are running 6 carousels and 1 is rest station. Next slide. So basically, everybody needs to understand that the marking system, how it works for each stations. So there's 168 marks in total to score, and combination skill station, that is station in the 1 or station 4 is 16 marks each. For each systemic examination like respiratory, cardiovascular, neuro, and abdo, it is 20 marks each. And for the BCC station, that is consultation station 2 and 5, there are 28 marks each. So these are the 2 stations which carries maximum marks. Next slide, please. So these are the different things also apart from the stations that you are marked on. So physical examination skills and identifying physical signs, that A, B, and then C is clinical communication, D is differential diagnosis, E is the clinical judgment, and F, managing patient's concern, and last but not the least, G is maintaining patient's welfare, which is very important for patient PACES exam. And all these skills, these 7 skills are marked in different stations. I'll explain how. Next slide, please. So in communication station, you are marked for CEFG. Respiratory station is again you are marked for 5. Since definitely you can see that all the stations have this G, that is patient's welfare. So which is important for every station. For brief clinical skill consultation, that is BCC, you are marked on all 7 of this. So that is the reason that station has maximum time and the highest marks and the highest score to get 28 marks and 20 minutes. Next slide. I think we can skip because already Dr. Biswas and Dr. Pushkarna has already discussed this in detail. So we can skip next 2 slides. Yes. So next slide, please. So this is the previous one. Yeah, this one. So this is how you are scored for all this sort of 7 skills that I've spoken about. So apart from each stations, there are mark distributions in this sort of different 7 skills. So you can see that clinical communication has 16 marks, differential diagnosis 24, clinical judgment 32, managing patient's concern 16, and maximum marks in patient's welfare, and 24 marks in patient physical examination. So you have to not only pass the stations, but you have to also pass these 7 different clinical skills that you are tested for in the PACES exam. Next slide. Next slide, please. Yes, so this is a scoring mark sheet. So this is for station 5 and 2 that I explained that you are marked for all the 7 skills, A, B, C, D, E, F, G. And you can see that obviously satisfactory, borderline, and unsatisfactory. These are the 3 sort of marking that you can get from the examiners. And they put up comments if they're giving you an unsatisfactory or a borderline marks. So basically, satisfactory for each station, can we just sort of zoom it a bit? Yes. So for physical examination, professional, focused, and systemic examination relevant to the specific case. We have already discussed that Varun has nicely elaborated that keep it specific, keep it sort of relevant and system-wise, be systematic, be correct and thorough and fluent, but don't be too long and waste unnecessary times. Then identifying physical signs. Definitely that is important, that you have to identify the physical signs to arrive at a diagnosis and conclusion. And then clinical communication skills like sort of that elicits appropriate and comprehensive history relevant to the clinical examination. That is important for BCC station 2 and station 5. Assess impact of symptoms and identify patients' preferred management options. So you have to discuss in station 2 and 5 at the end of your examination and history taking skills stations. At the end of the station, you have to discuss about your plan of management with the patient. So that is important. So you have 14 minutes to 6 minutes to discuss. So you have to keep the timing. Then obviously differential diagnosis and clinical judgment, you're also marked for managing patient's concern, like you get a good mark if you seek and detect and acknowledge and address patient's specific concerns. If you overlook or fail to address patient's concerns or relative specific questions, or you're a poor listener and lacks empathy, then obviously it is going to give you an unsatisfactory score and you're going to fail the station. And managing patients' welfare. So treat patients or relative, if it is a commercial skill station, respectfully and sensitively, ensuring comfort, safety, and dignity. That is very, very important. If you cause any patient or relative physical or emotional discomfort or distress, or jeopardize patient safety, you are not going to pass the station, especially in station 2, 5, and communication skills. So these are things that comes with a bit of practice, and that is what we are going to sort of, give you a lot of practice in our course, and also sort of give you tips and tricks about how to score in this sort of different stations and score good satisfactory marks for each stations. Next slide. So this is kind of a report card that you get in the PACES exam. As I explained, that total available marks is 168 and the pass mark is 126. So you don't only have to pass in total marks, but also you have to pass in the 7 skills that you are tested for. So for communication skill station, sort of, if you have 16 marks, and for respiratory 20, for concentration 128, cardiovascular and other clinical skill stations 20 each. Then when we come to those 7 skills that you are separately tested for in each stations, those carries, as I already explained, the marks for physical examination. So you have 24. You have to get 16 out of 24 to pass the PACES exam. For identified physical examination, physical science, you have to get 14 out of 24. For clinical combination, you have to score 11 out of 16. And for differential diagnosis, you have to score 15 out of 24. And clinical judgment, 20 out of 32. And managing patients concern, 10 out of 6. And especially welfare, 28 out of 32. So this is the most important thing that you are tested for in PACES exam, that is patient's welfare. So what I'm trying to explain here out is that how you have to pass all the stations together, get a 126 score, but also you have to individually pass in this individual skill things that you are tested for, the 7 skills that I discussed. So you have to pass in all those 7 skills individually. And if you get 126 and pass all these stations and get pass mark for all these sort of 7 skills you are tested for, you pass exam. So this is important. That is the final grade you were given after calculating the total marks as well as the marks divided into those 7 skills. Next slide. Keep in mind, the top tip for PACES exam is that it is helpful to remember that just because you may have performed poorly in one station, it doesn't mean that you will perform poorly in the next station or even fail the exam. So try your best to focus on the next station in front of you during the 5 minutes break. Utilize that time to focus on your next station. If it is communication skill or BCC station, then read the sort of station properly. You can write down some notes and utilize the time to prepare for the station rather than actually thinking about what happened in the last station and also do badly in the next station that you are going to face. That is important. Don't carry the hangover from the previous station. Every station is a fresh new beginning, and you have to try your best to pass that station without thinking of what has happened in the exam or the previous station. So that is the end of my presentation. So this is for the PACES exam. What we are going to do, help you all with during our course, is that you will be given ample opportunity to practice all these skills, all these stations. We run the course for 3 days, and apart from small talks in the morning, like maybe 4 or 5, 15 minutes each, in sort of giving you an look or idea about how to approach those stations, most of the time is used in sort of doing practice for all the stations, including the communication skills, BCC, and for the clinical skills, you get all real patients who are sort of divided into different groups, uh, and you get exposed to all the stations, all the sort of possible scenarios that can come in the physics exam, as well as all the kind of patients that you actually encounter in the real exam. And on the day 3, the mock tests day, we run two complete mock tests to give you a real feel of the physics exam. And you are also given a mark sheet and feedback at the end of the examination, mock examination. So that is to actually prepare you for the real exam, and also to make you confident that you can how you can prepare best for your exam, and how you can approach, as well as how uh, to improve to pass the exam, real exam. So, any questions or any sort of queries at this point of time, we can take up now. We are already, it's not 9:15, so maybe 10-15 minutes we can have for the question and answer session or some discussion. You can put up your question in the chat box also, or anybody wants to ask anything, please feel free to do so.
One question we have received, that is, where is the lectures? A candidate is asking where he can get all the PACES lectures of Farz Academy or any other.
I think, Rasif, you want to take that question? I mean, we would send you a link once you register for the course to prepare for the with the online material before the actual course. So you come prepared with some kind of background knowledge for the real course, because we want you to utilize these 3 days completely uh, to practice and improve on your clinical skills as
এই
well as
তোরা বস,
communication
আমি
skills.
এটা শেষ করে আসছি।
Okay, so that is what
Yeah,
we
I
want.
think Shana, what lecture you are talking about? Mane, this is the regular lecture. What?
So the candidate is asking about where he can get PACES lectures. I believe so. The first thing is you can get enroll yourself to Farz Academy, which offers online and offline course both.
Yeah. Once the candidate can enroll, then they will get the free access of the library where all the lecture is there.
Yes.
Lectures
Plus,
as well as videos of each stations, video
Yes,
yeah,
yes,
recordings,
yes.
how to
and also,
sort of.
yeah, we have live lectures also of PACES.
Yeah.
And the next question we have here is, how much time is needed to prepare
Hey,
for PACES exam?
Yes, so basically depends on your experience. So if you are sort of working in the clinical medicine or related specialties for say at least a couple of years, then you probably need few months, 2 or 3 months, couple of months to 3 months maximum to prepare. But if you're sort of experienced with sort of encountering and seeing patients in the clinic or in the IPD, then obviously you are already there with the clinical knowledge and sort of some kind of skills which just need to brush up for the PCC exam. As you said, it's not like, PCC is just testing your clinical skills, and they want to see that you are a safe doctor and you are actually already sort of you have been tested for your knowledge in PCS before the PCS exam. There must be part 1 and part 2 exam. So you're already prepared with your knowledge. So that is the time that you already feel that, I know enough from medicine. I just need to practice my clinical skills, brush up my skills, and then take up the real exam.
There are another question is that how much time is needed to prepare for PACES exam? Tanmoy, can you address this question?
I think I have already addressed this question actually. So as I said, usually if you are a trainee in medicine or you are working in medicine with kind of some clinical experience for 2-3 years, then you probably need 2 or 3 months to prepare for it. And if you are just a fresh pass out, then obviously you need to first prepare for the MRC Part 1 and Part 2 exam. You need to develop your clinical knowledge and knowledge about internal medicine, and then you approach the PACES exam clinical skill stations and practice them, try to sort of see patients in real life. So our next PACES course is going to be 13th to 15th of February 2026 in Kolkata. And that is to target for Diet 1 of 2026 PACES exam, which is going to be held in different cities. This time is appropriate for the course for any examination candidate who are taking the exam in Kochi, New Delhi, Jaipur, Chennai, Kolkata, Mumbai, or Thiruvananthapuram. So basically, these are the exam dates in these centers are usually what is sort of known are given later in the February 2026 or March or early April 2026. So anybody who is planning to take up the exam in these centers, this timing of the course is going to be perfect for them. As we said, somebody has already decided or sort of got a place for the PACES exam. You need to start preparing from now if you have not already started. So 2-3 months of preparation and practice, especially if you have a fellow candidate who is also taking the exam, practice with them. In the course, when you come, you're going to get a lot of opportunities to practice and sort of build up your confidence for the real exam. Can we show our sort of course schedule that we sort of followed for the last diet when we held the course in October 2025? So
Sure,
can
sir.
we have some idea about how we run the course? What is the structure? So as I said, first day, obviously after few brief lectures for say 1 to 1.5 hours, we go directly into practice. First, we start with communication skills and then station 2 and 5 BCC. We have a lot of scenarios, lot of and opportunities to practice all those skills in the first half of the first day. Then in the second half of the first day, after the lunch break, we have clinical skill practice sessions with real patients. So all bedside practice. We divide into small groups of 2 or 3 candidates and they rotate amongst all these stations for clinical skill practice with real patients. Then day 2, again, a lot of practice stations. So where we actually run it like the PACES exam stations. So cardio, respiratory, neuro, gastro, and then communication skill and BCC stations. You need to practice all these stations for the exam and for the mock, get ready for the mock exam on the day 3 as well. And we teach and give feedback on day 1 and 2 for each stations, and we discuss how to approach all these scenarios and stations. On day 3, you get a full mock test in the first half, mock exam 1, and then on day 3 afternoon, after lunch break, you get another mock exam, full mock exam, where you actually rotate as like in real PACES exam, doing different carousels. Then at the end of the day, you get results and get detailed individual feedback. So this is a structure we follow, and that was for the October, but in the February, we are going to follow the same structure. So you get a lot of opportunities to interact with the patient, the examiners, to the actors, surrogates and see a lot of different clinical uh, stations in neurology, cardiology, respiratory, and gastroenterology, different clinical signs, and sort of get ready for the real exams, because we actually have patients from different systems which are sort of going to give you an exposure into all the kind of scenarios that you can encounter in the real PACES exam.
I think, student, if you have any further question, then is okay. Otherwise, we will close off. We'll end up here. So, if you have any question, we are organizing our the next PACES course, the physical PACES course on 13th February, 14th February, and 15th February in Kolkata, India. And it will be we will keep at least 100 cases, different cases, and it will be as similar as the original carousel. And also we have started our online courses. If you are planning to give in the next year first diet, that is on the exam will start from the February end till March end. So if you get already got the seat allocation, then you can join with us. You can start preparation. We have the very experienced faculty and well structured courses. So, Kolkata location is in Salt Lake, HP Ghosh Hospital, where we are conducting our next PACES course.
Thank you, sir. I share some glimpse of MRCP PACES course. So I'll be sharing my screen.